The views, opinions, and content of this show are those of the host, guests, and callers. They do not necessarily reflect those of Local Matters Broadcasting, LLC, its owners, partners, affiliates, assigns, or heirs. Having said that, it's now time to say good morning, St. Johns County. Welcome to the weekly radio show of the St. Johns County Council on Aging, better known in our community as the COA. We are your local nonprofit agency who for the past 52 years has been leading and advocating for the dignity and independence of seniors and responding to their changing needs. I'm Brian Robinson, Program Director for COA, broadcasting to you live from the studio of WFOY 102.1 FM, your local radio station for news, sports, and talk. Before we get into our show, let me remind everyone, as I do each and every week, if you have a question, comment, or a suggestion for a radio show topic, or while you're listening today, if you have a question, you can send that to radio@coasjc.org. Again, that's radio@coasjc.org. And I do have my email up in front of me, and I'll be monitoring that, and we'll try to work your question into the show if you send it to me. So again, it's radio@coasjc.org. All right, joining me this morning is Kristin Maclao, who is a psychiatric mental health nurse practitioner who graduated from Jacksonville University and has 4 years of experience in the field. She currently works at Florida Center for TMS, where she specializes in treatment-resistant depression and interventional psychiatry, focusing on helping patients find relief through personalized, evidence-based treatments. Good morning, Kristin.
Good morning.
It's good to have you on the show. Thank you so much for taking time out of your busy schedule, and I'm sure your schedule stays very busy with lots of patients throughout the day, so thank you for working us in and talking about a topic that is very near and dear to me, and that is depression, because I have personally dealt with depression off and on since I was a teenager. And so I'm very familiar with it. So looking forward to having that conversation. But one of the things that I like to do in this very first segment is just let our listeners get to know a little bit more about you. I've talked about where you had your education and where you're currently working at. But tell our listeners a little bit more about you, like where you're originally from, how long you've been in the St. Johns County area, and things like that.
Yes, absolutely. Thank you for having me. So I'm from the Northeast Florida area, kind of from back and forth between Jacksonville, Amelia Island, St. Augustine. For most of my life. Yeah.
All right. And that's great. So you're a native to the area. And so I'm originally from the north. So I moved down in 2018 and just been enjoying all the lovely weather. And the weather for me has been a great thing for my depression, because being able to be outside more and more sunshine, and that has been very helpful for me. And so as we dive into this topic this morning, we're talking about, treatments for depression, specifically ones that you use at the Florida Center for TMS where you work at. And so as we jump into this, though, let's talk about somebody listening today who maybe knows very little about depression, because if you've never had depression, it's very difficult to sometimes understand what somebody is experiencing. It is a serious medical illness, and it does affect about 20 million Americans. And that includes about 15% of those of our senior population. And that's why I wanted to have this conversation today, because at Council on Aging, that's who we're serving, people 60 and older. And so about 15% of people in that age group deal with depression. And so if you would, just give a great, kind of a layman's term definition of depression so that our listeners can have a better understanding.
Yeah, absolutely. So depression is more like, I guess, a cluster of symptoms. And it can be things from the more traditionally things we think of like sadness and crying, or it can be other things we wouldn't think of like difficulty sleeping, changes in appetite, motivation changes, irritability, not enjoying things that, you might have really enjoyed in the past. So the key thing is having those symptoms, a specific number of those symptoms, and for a certain amount of time. And oftentimes people have depression that comes and goes, as in it will get better for, 3-6 months, however long, and then come back again. And that's recurrent depression.
Mm-hmm. And that is something I've personally experienced from my teenage years. And so I know firsthand what you're talking about when you talk about recurring depression. And for me, I think, sometimes it's not about sadness, but sometimes it's about getting to a point where you feel emotionally numb. So you're not feeling sadness, you're not feeling joy, there's like no emotion, and you kind of just feel like you're going through the motions of life, right? And so for me, my mental health, medical professionals, they kind of identified me as a high functioning person with depression, meaning I could still go through life and do the things that I needed to do, but on the inside, where people can't see what's going on, right? It was just a hollowness and a numbness. And so that's an accurate description as well, would it not be?
Yes, absolutely. And a lot of people, go through life thinking, well, I get up and go to work. I do the things that I need to. I take care of my family, so I must not be depressed. But that's not, the case for everyone. Sometimes people's depression looks like I can't get out of bed, I cannot function. And sometimes it looks like just going through the motions, like you said, and kind of just like feeling numb to everything. You're not really overly sad. You're not happy. You're just kind of cruising along.
Yeah, and I think that's important for folks to know that, because so often we do think, well, it's somebody who's extremely sad, right? And so then they don't realize that they have it. And so I think sometimes folks don't get the help that they need because they think that they're okay. And so that's what I really want our listeners to kind of tap into this morning, is that, as we're talking about this, and maybe they've been having some, things going on and they don't know what it is. And it's okay to seek help. And that's one of the things that I'm trying to do for myself, is be an advocate, to say, you know what, it's okay to not be okay, and it's okay to ask for help and seek help. And that's why, professionals like you do what you do.
Yeah, that's probably one of the biggest challenges I see is it's very generational, and, people think it's a weakness, and, it's not. It's like more, they feel like it's more of a character flaw versus actual disease process or health condition, which is not accurate. I have patients that, come in and they tell me they're even depressed because they feel depressed. They feel guilty because they're like, I have everything. Why do I feel like this? And I explain to them, it's like, any other medical condition you have, it's not always something that can be explained or changed with just behavior. Sometimes you need treatment or medication.
That's a very good point. My father, he was an alcoholic. And so I feel that for him, especially his generation, his generation didn't seek out help for mental health. So I think for him, he was self-medicating his depression. And so sometimes that ends up happening where folks, they're because of the stigma, they don't seek the help. And so then sometimes they end up relying on something that they shouldn't, such as drugs and alcohol.
Yeah, very common. And, that comes down to us, like as clinicians, needing to be able to see, hey, this isn't a true, substance use disorder or alcohol use disorder. This is more of like a depression that is being treated in a maladaptive way by drinking or drugs or whatever it may be.
Mm-hmm. And so as somebody comes into you, you're able to kind of identify whether it's a substance abuse disorder or they're dealing more with depression and self-medicating.
Absolutely. Yeah. Usually I can kind of talk to them and get down to the root, like, what makes you drink? Why did you start doing this? And also another key is typically when they start feeling better depression-wise, then they find they really aren't as interested in the alcohol. I mean, obviously that is an issue that has to be addressed, but sure. A lot of times with people who are just using it secondary, I see when their depressive symptoms improve that they aren't wanting to do those things anymore.
Yeah, that's great. And that's got to be a great victory for them, realizing that the addiction is stemming from the depression. And then once that gets treated, then they get that freedom from that addiction. So, and I'm sure that's so enjoyable for you to see them get that victory.
Absolutely. Yeah. Seeing the success cases makes it worth it.
Yeah, absolutely. All right. Well, we're going to take our first break right now, and we'll continue our conversation right after these messages. We'll be right back. And welcome back to the weekly radio show of the St. Johns County Council on Aging here on WFOY 102.1 FM, your local radio station for news, sports, and talk. I'm Brian Routson, Program Director for COA, joined this morning by Kristin Maclao, who is a psychiatric nurse practitioner with the Florida Center for TMS. And before we continue on with our questions, let's talk a little bit about the Florida Center for TMS. I just want to make sure you get a little plug in there. So yeah, from your website, it looks like you have 3 different locations, including one here in St. Augustine.
Yes, absolutely. We offer several different types of services and treatment. We do medication management, TMS, Bravado therapy. So we kind of, and then also we work with St. John's Center for Clinical Research to do some of our clinical trials and stuff.
Okay, great. So a variety of different options there, treatment options and different things that you do there. We'll dive into that a little bit more here as we continue our conversation. So one of the things that I did want to talk about today is the similarities and differences between seasonal affective disorder, also known as SAD, and major depressive disorder, because there is some similarities but also some differences. So I was wondering if you would kind of educate our listeners on that.
Absolutely. So I will say this, I'm definitely not an expert on seasonal affective disorder because it is something that's not really common in Florida. It's more common in up north in states such as Alaska that have the, sometimes 24-hour days and nights. But what I do think we see in Florida is that people who have depression might see worsening of symptoms during the wintertime, as they're not getting out and as active as much and not getting as much sunshine and it's cold and holidays can also play a factor. So I will say the difference, though, is that with seasonal affective disorder, typically it's very linked to wintertime and then will resolve in around spring. And one of the best treatments is going to be light therapy as well as medication.
Yeah. And then, and I agree with you that we don't see it as much in Florida. I definitely experienced it more when I lived in the north, right? But one thing that does still come into that plays a role here in Florida is the time change, right?
Yes.
So fall comes around and we fall back and we lose that extra hour of daylight, and then you get into the winter months and it's dark by 5 o'clock. And for someone like me, I enjoy after work getting able to get out, do my 3.5 mile run, being outside in the sun, which like you said, springtime comes around and things start to feel better. So even as somebody who has dealt with major depression at a point in my life in my mid-30s, I've also experienced the seasonal part of it as well. So I'm always glad when spring comes back and rolls around. And the north is nice because snow is pretty. If you've never seen snow, you need to get up north and experience it. It is pretty. It is fun to play in, especially if you have kids, right? People like to ski. That's enjoyable. No fun to drive in. No fun to shovel. I can attest to that. But it is so much better for my mental health living in Florida. And so I just wanted to bring that out that, there is some distinctions between seasonal affective disorder and major depressive disorder. So tapping into the major depressive disorder, though, what are some things that you look for? Like that's a little bit more serious than just regular depression, right?
So when we say depression, we mean typically major depressive disorder. We could mean someone has an adjustment disorder, and that's like more of like a situational thing. Say you have a loved one that passes, or dealing with a divorce or a difficult family time. You might, have some depression briefly, but it's not lasting long enough to be considered major depressive disorder, what we traditionally think of as depression, and that's 6 months of symptoms. Or maybe it's 3. I'd have to double check it. It's 3 or 6.
Yeah, for adjustment disorder, it usually takes about 6 months, from what I understand, for somebody to get through that and get back to where they're back to like they've adjusted to the situation. So, like you said, a death of a loved one, whether that's anticipated or unexpected, right? I mean, you can still anticipate somebody's death, right? Because they have terminal cancer, and that it's on the way, but it's still an adjustment after that person passes. And so, from my research, it's usually 3 to 6 months for someone to get through that. So that's I'm glad that you brought that up, because that's definitely something that folks deal with. I know that's something I've personally dealt with myself as well. Let's talk about, and we'll jump into some of these other questions, but let's talk about the importance of therapy, talk therapy, because for me personally, in my mid-30s, I got diagnosed with major depression. Okay. And then started seeing a psychiatrist, and eventually was, put on different medications. And what I didn't have money for at the time was talk therapy, to get into counseling and to really dig deep into what the root issue is, right? And so, but in recent years, and this is a big shout out to Florida Blue, there's no cost now for the copay for some of the different things that they offer, right? For some of the different plans that they offer. So for my plan, there's no copay. So and there's no limit. And so it's very affordable, right? So I've been taking advantage of that. And it has been a game changer for me to do the therapy and kind of dig into the the root of some of these issues that I've dealt with throughout my life that have been a cause of the depression. And so for you, is that something that you have found helpful for your patients as they get into, you recommend it and they get into it? Have you seen some of your patients recover quicker if they're into therapy?
Absolutely. I think it's an essential part of treatment. And my patients who do therapy have, I feel like, faster results and more sustaining results, lasting longer. So I think therapy is definitely essential. You're right. They do offer so many ways to access therapy now. And some healthcare plans, a lot of times, if you go on your insurance website or portal, they offer like partnerships with certain companies and do like virtual telehealth therapy. And sometimes if you go those routes, it could cost nothing versus other ways. So I always encourage patients to look at that option too, just to give them the most affordable access to therapy.
Yeah, because sometimes we don't know what the root cause is. And so then when you get into that therapy, that therapist who's trained, right, spends years training to know, how to deal with it, helps walk you through that and helps you to, kind of identify some of those. And that has certainly been the case for me. So one of the things that I'm doing, and we'll talk about some of the treatments you do, and I didn't notice this on your website, but I've been participating in the EMDR therapy, which has been very, very helpful. So any experience with that?
Yeah, not me personally offering it, but I do have a lot of patients who do it, and it is very effective especially for trauma and PTSD, which depression often is accompanied by other diagnoses. I mean, sometimes occasionally I have someone who's just straight depression, but a lot of times mental health diagnosis is kind of clustered together. So it's not uncommon for me to see someone who has PTSD and depression or some other things that could be worked through with EMDR.
Yeah, and I have found that to be the case for myself. Some things from my childhood experiences that I never had a chance to deal with, right, led to a lot of negative thinking about myself, which then led to the depression, right, has tied into the depression. So I think from a physical standpoint, right, I think I have a genetic disposition to it, but then you tie in experiences that you've had in life, right, and those kind of can kind of be like triggers to then trigger that in you to cause the depression. Accurate?
Yeah, I think that is very accurate. And also another thing is some people are hesitant to do therapy because they don't want to dig into the past.
Mm-hmm.
Obviously, a lot of times it is effective, like for you to dig into those things and process through those. But I encourage my patients, even those who don't want to do that, you can be very honest with your therapist and say, hey, I don't want to rehash past traumas. I want to know what I need to do now to feel better. And that's okay too, because they can do therapy based on that too. You don't always have to dig into everything, even though it probably would be very helpful. But I think it shouldn't be a reason to discourage patients from, seeking out therapy.
Absolutely. And that's what I appreciate about my therapist is she does not force me to talk about something that I don't want to talk about, because some things are too difficult to talk about. You already experienced it once in your life. You don't necessarily want to dive back into and experience it again. So great point. I'm glad that you brought that out. So we'll have a commercial break coming up here in about 10 seconds. So we won't jump into our next question. We'll just wait until the commercial break kicks on. And so we are having a wonderful conversation with Kristin Maclao, who is a psychiatric nurse practitioner with the Florida Center for TMS. And we'll continue that conversation right after these messages. And welcome back to Weekly Radio Show, the St. Johns County Council on Aging here on WFOY 102.1 FM. Your local radio station for news, sports, and talk. I'm Brian Robinson, Program Director for COA. Next week in the studio, we'll have COA's Amy Robinson and Carolyn Carger in the studio to talk about different things that are going on at COA and in their world of development. So looking forward to that conversation. Let me also just remind everybody that we do have the construction project going on down on King Street. And so FDOT announced that it closed the King Street Bridge over the San Sebastian River on US 1 in St. Augustine. That started April 13th. And so there's a detour in place, and that's going to be in place for about 7 months if the weather and everything else cooperates. So it could be longer. And so if you're heading down our way at our main location, 180 Marine Street, or to River House right across the street at 179 Marine Street, make sure that you give yourself a little bit more time, or you may want to come in the back way and come across the Bridge of Lions. So just make yourself aware. You might need to take leave a little bit earlier to come down and be at our main locations on Marine Street. All right, joining me this morning is Kristin Maclao, psychiatric nurse practitioner with Florida Center for TMS, and we're having a wonderful discussion about depression and the treatments for depression. And so one of the things that I personally have experienced is the fact that sometimes medication is really trial and error, and medication is typically given that focuses on serotonin, dopamine, norepinephrine. I'm not sure if I'm pronouncing that one correctly.
Yeah.
But in my experience, it's usually, trial and error. You might try medication for a little while. It's not working, so you got to adjust it. Sometimes you might have to tack on another medication to go with it to kind of balance it out and so forth. And so it's really just a trial and error approach. But even with that approach, not everybody responds to traditional antidepressants. And so there's something on your website that you do at Florida Center for TMS called Spravato. And so tell our listeners more about that treatment.
So Spravato is really good, and it works. It has a different mechanism of action and works differently than our traditional oral antidepressants do. So a lot of times when patients don't respond to traditional antidepressants, we can go with Spravato, and because of its different mechanism, it is more effective for them. It is a nasal spray treatment, and they do have to come twice a week for the first couple weeks, and then we kind of taper to once, and then maintenance is every 2 weeks. But it's a good option for patients who haven't responded to antidepressants in the past.
And then from what I read on your website, it is something that you kind of have to observe the person after they do it just to make sure that they're responding to it properly, correct?
Yes, absolutely. The patient would be in the office for 2 hours. They're in a nice comfy little recliner in a comfy room, and they stay for 2 hours. They have to have someone bring them there and pick them up because they're not able to drive again until they go home, go to sleep, and wake up the next morning.
Mm-hmm. And so is this like an ongoing thing, or is it like a first couple of times that they do it just to make sure that they're responding well to it?
It's ongoing. So the way that the type of controlled substance it is, it has to be done in office. It has to be monitored.
Mm-hmm. And then what type of results are you seeing with folks?
Spravato is very effective. I couldn't give you an exact percentage, but I would say that definitely the majority of my patients who've done Spravato have had a positive result from it. I think I've only had a couple who ended up saying they didn't have any improvement.
Okay. And this is, again, not knowing a whole lot about it. So is this a experimental drug, or this is one that's gone through a lot of clinical trials? It's been approved by the FDA, and it's, something that's been being used for several years now?
Oh, yeah, absolutely. Spravato is FDA approved. And it has been around for, several years. I don't know the exact number, but definitely more than 5, I would say at the least, because it's been around since I started working in psychiatry. So it's definitely nothing new. Side effects are, minimal. There are some present, during that short period of time when you are getting the treatment, but typically very well tolerated. And like I said, it's not new. It's been evaluated for very thoroughly for safety.
Okay. And then is this something that somebody's on for like the rest of their life, or is it like a short treatment period?
So ideally, we would like them to do the Spravato, get well enough where they can actually have the motivation and be able to put the effort into therapy, work on the things that are bothering them, and eventually taper off of it. But a lot of times, I'll be honest, patients do end up staying on it, more of a long-term maintenance thing, because it's not, I understand life happens. It's not always easy to do the things that we need to get better. So it kind of can go both ways, but we hope that it won't be a lifelong thing.
Mm-hmm. And so this would be kind of something, so you've already put somebody on the typical antidepressants. They've been on it for several months, maybe a year, maybe 2, and they're just not responding to them like you would like for them to respond. And so then this treatment would come into play.
Yeah, so typically I recommend TMS first.
Mm-hmm.
If medications don't work, because it has less of a long-term burden on the patient, as far as having to do maintenance treatments, ongoing TMS. Once you've done it, you've completed it, you don't have to keep coming. Now that doesn't say that it's going to last forever. I mean, some people maybe will never need it again, but it is less of a burden for the patient long-term.
Mm-hmm. Okay, so let's talk about TMS, and correct me if I'm wrong. I did some research on it, but it means transcranial magnetic stimulation.
Yes.
correct? Okay. So TMS for short. So let's first give a description of that, and then I got some follow-up questions that we'll dive into. So tell our listeners what TMS is.
So with TMS, what we do is we use a magnet to stimulate the electrical activity in the brain, because we found that, depression isn't just one thing. It's not just chemical imbalance. It's not just situation. It's many, many factors. And one of those things we found is that patients, their neurons aren't firing and talking and communicating effectively. So TMS stimulates that activity and kind of is like physical therapy for the brain. Like, it's teaching your brain how to do those fire over and over again and rebuild those connections so it can keep doing that, talking, passing chemicals, and working in areas that maybe you had some, I guess, in areas that or maybe not working as well as before.
Mm-hmm. So something interesting I love reading about this stuff, and I'm so fascinated with neuroscience. And so I was reading a book, and something that I discovered recently is that we used to believe that you were born with all the neurons that you would get. And then recent research, from what I've read, we've discovered that your brain can make new neurons. And so as people are doing this therapy, is it helping to also create new neurons?
I would say maybe not create, but maybe rebuild some previous connections that kind of weren't there. But, I'm not 100% sure on that. I'd have to double check on that.
Mm-hmm. Mm-hmm. And so then the treatment is also been going on for how many years? Like
17, 18 years. It's it's been around. It's been FDA approved for a very long time. Very safe.
All right. That music means it's time for our next break. We'll be right back after these messages. And welcome back to the final segment of the weekly radio show of the St. Johns County Council on Aging here on WFOY 102.1 FM. Your local radio station for news, sports, and talk. I'm Brian Robinson, Program Director for COA, having a wonderful conversation this morning with Kristin Maclao, who is a psychiatric nurse practitioner with Florida Center for TMS. And we're talking about TMS in the last segment. We're going to continue talking about it. It refers to transcranial magnetic stimulation. So let's just get some follow-up questions in here. Insurance. People are going to want to know, does insurance cover it?
Absolutely, yes. I think most, if not all, insurance plans do cover TMS.
Okay, wonderful. Here's another question. Does it hurt? Because I do not like pain, so I don't want to come if it's going to be painful. And I'm sure there's lots of people out there listening that might be asking the same thing. Is it going to hurt?
Yeah, so everyone asks me that question, and I always have a hard time answering this because it's really not painful. I've had them hold the magnet on my head and test it so I could feel and explain it to my patients, and it doesn't really hurt. It just feels like a tapping, so it's kind of a weird sensation. But I'll tell you, we've done TMS on tons of patients up into their late 80s, and I've never had anyone be like, I can't do this, and hop out of the chair. So it's more of it's just a different feeling. It's feels like someone's tapping on your head kind of strongly, but it's not really painful as well. It's just more of a getting used to the sensation. And typically after the first week, patients are like, okay, it's no big deal.
On your website, you say there's a couple of people that would not be eligible if you have a metal plate in your head. Of course, you can't do that because it's a magnet, right? And then also if you're prone to seizures.
Yeah, absolutely. And I would say still, even with those two situations, it would be good to come and get evaluated anyway, because depending on what happened, for instance, a patient who might have had a febrile seizure when they were a child, okay, that might not we might not count that as a true epilepsy seizure disorder, so they could still get TMS. Or someone who has a plate and depending on where it's positioned in the head and how severe their symptoms are, we might work with neurology or whoever placed it to kind of determine, hey, maybe we can do TMS as long as we're, avoiding that area. So I think it's always good just to come and kind of talk to us, and then we can kind of dig a little deeper and find out if you're a candidate or not.
Okay. And so my mind is very inquisitive. So random questions pop in my mind. So what about cavities that you've had filled? Does that any issue?
Nope.
Okay.
Not at all. Yeah. No cavity issues. And surprisingly, a lot of things that they used for surgical procedures or implanted devices, depending on what it is, a lot of times they are compatible. So the big thing is I always ask, like, are you MRI compatible? If you can get an MRI, then you can get TMS.
Okay, good. Yeah, fillings, that's what I meant to say instead of cavities.
Yeah,
Cavities are filled with fillings. Yeah, so that's where my mind went. I was like, oh boy, what if like all my fillings would start coming out?
Oh yeah, I asked that question myself when I first started. I was
Did
like,
you?
what about even the old fillings that were done a long time ago? They're like, no, it's fine. I'm like, okay.
Great. Memory loss, can it contribute to any memory loss, short term or long term?
No, I've never seen that, and I don't think that was reported in the clinical trials at all. I think that sometimes patients even have memory problems when they're depressed, and I see that those cognitive functions kind of improve as we do the TMS.
Mm-hmm. And then as far as results, I mean, we talked a little bit about that, but how quickly do you see the results?
So in the clinical trials, it was day 21, but I will say every patient is differently. Sometimes we have patients like will be a weekend and they'll be like, wow, I'm already starting to feel great. And then sometimes, not as commonly, much more rare, it'll be like a week or even 2 weeks after treatment that they get the improvement. I will see most of the time it is hovering around that day or session 21. So that's typically about 4 weeks in, 3 to 4 weeks in.
Mm-hmm. And then does the length of time factor in? So let's say somebody's been dealing with depression for 30 years and they've been on medication, but it just still isn't doing the trick. And so then they come to you. Does it take a little bit longer for those folks?
In my experience, yes, sometimes it can. That's why I always encourage patients, to seek out TMS as soon as possible. Sometimes people think, well, I've only tried 1 medication or 2 medications. I don't think I really am that sick or I'm not severe. But I think that it's always best to come sooner, and then, we can decrease maybe your medication burden you're going to need lifelong.
And I guess some people might be thinking about like in old times, or maybe they still do this. I'm not super familiar with it, but when they used to put electrodes on it and put
ECT.
Electricity through. Yeah. So first of all, is that still being done?
Absolutely. Yes.
Okay.
And it's not like, One Flew Over the Cuckoo's Nest or anything. Like it's a little bit different now, but it is really effective. But it's way different from that. That is used for depression, but comes with a pretty significant side effect profile and things like that. So TMS is different. It is focusing on a certain area of the brain, whereas ECT is kind of like the whole brain, and which can lead to side effects and things like that. So very different. So recommend TMS first for sure.
Okay. So when you say TMS is focusing on a certain part of the brain, do you first do like an MRI of some sort to find out which brain is functioning best and not, and how do you determine where to focus it?
Okay. So yeah. So what the psychiatrist does is she or he will actually take measurements of the head and use those measurements to kind of determine a starting point for her to test where the magnet needs to be placed. And it's not via imaging. It's more of kind of like a motor response that we look at, like kind of like we'll have you hold your hand, and when it kind of twitches, then we know we're at a certain area of the brain, and then we kind of move away from that to get in the right position. But it is based on measurements and positioning that the psychiatrist does. As far as the scans do, So as far as the scans go, we don't do them as we're doing TMS, but when it was being studied in clinical trials, they did do PET scans to see what areas of the brain were not lighting up, which ones need to be targeted, and, found that, we need to look at the left dorsolateral prefrontal cortex. And so that is the area we target and measure for.
Oh, that's fantastic. Okay. Well, that's great. I mean, that's good to know, because initially I'm thinking it's just like you're putting the magnet just on the whole head, but you're zeroing in on the part that it needs to be focused on.
Absolutely. And that is what makes it, safer and has lower chance of having side effects like seizure and things like that, because we are targeting a specific area versus having more of a chance to bounce and hit other areas of the brain.
Okay. So also on your website, I noticed that you do clinical trials. And so or do you have any that you're currently doing, or ones that are coming up in the pipeline that maybe somebody out there listening might be interested in being a part of?
Absolutely. We have 2 clinical trials going right now. One is for depression and one is for bipolar disorder. Actually, we have 2 for bipolar disorder right now. And one of them is specifically looking for bipolar candidates with Medicare. So I would definitely encourage patients if they've maybe tried a lot of things and they want to look at some clinical trials to reach out to the St. John's Center for Clinical Research.
Okay. And then how does that work? I mean, the cost is completely covered for the patient?
Absolutely. And I believe there's compensation too for the patients for the participating. I don't know how much it would be based on the trials, but I know that there is. And the cost is covered, yeah. And a lot of times, sometimes, we're not trying something that might be brand new and very, it might be something that has been around, but we're trying it in a different way. Mm-hmm. So sometimes it's not as scary as patients would think.
Okay. And then there's in a clinical trial, you're going to have some folks that get the placebo.
Yes.
Yeah. And then you don't know whether you get the placebo or not. And what's interesting sometimes in some of the trials is sometimes people get better because they think they're getting it. And so that comes into play too when you're doing the research, doesn't it?
Absolutely. And I think that's kind of the biggest reason why we do it is to make sure it's not just because they, think they're getting it. It's truly the medication. And also a lot of clinical trials, depending on which one it is, you might not get the medication while they're doing it, but say 12 weeks later or whatever the time frame is, then the clinical trial changes to where everybody gets the medication.
Okay. Very good. And then what happens for somebody that's in it and then they're just like, oh, this is too much? Like it's okay to drop out?
Absolutely. Mm-hmm. Yes. At any time, if you don't think it's a good fit, no problem at all.
Okay. So they're not going to reach out to you directly. They're going to reach out to...
Yeah, they can reach out to our office, which is fine, and they can direct them because we work very closely together. So that would be fine if they just reach out to us and we can kind of direct them where they need to go.
Okay. And again, that's Florida Center for TMS, and the website is floridacenterfortms.com. So if you go there, you can learn more about their practice and everything that they do, and give them a call if you're interested in their services or the clinical trials that they're doing. All right, that music means it's time for our show to end. Thank you so much for being here, and thank you everybody for listening. We'll be back in the studio next week. Have a great week, everybody.